you see it? Got it. Okay. Do you see it?
Yes.
Okay. So this is a, not an eye test. You can see patient has cirrhosis. She's relatively young. I forget how old. Actually, very young. The cirrhosis, she's congenital have either C or B. I forget. She's very young, in her 20s. You can see, pretty advanced cirrhosis. And she comes in with this lesion. Thoughts? Should I just go through?
I'll make comments, but anyone else who wants to make comments would be awesome. This is an arterial phase. It looks decent because there's mixing in the portal vein. The lesion looks like it has arterial enhancement with a central area of non-enhancement. I'm concerned about a HCC with maybe central necrosis.
So if you apply Lyrads, what would you go with?
I need to see the delayed.
Huh?
I need to see the delayed to see if there's washout.
You actually don't, right? Because this is rim arterial phase hyperenhancement. You agree? It's rim.
Okay.
Right? So
I was thinking that the bottom rim looks too big, it's most it. So if that rim though washes out.
Doesn't, so this is fantastic because the rule is if you're not sure, no, it is. It's a great illustration, right? So the rule is that if you're not sure if this is rim or non-rim, the rule is you go with rim because you want to preserve the the specificity of Lyrads 5 for HCC. So if you right, so when I show you this, right, and you're like rim or non-rim, okay, you have to go with rim. And so once you decide this is rim or arterial phase hyperenhancement, it's pretty much irrelevant what happens on the portal venous phase because once you have one targeted feature, that's enough to call LRM. But since you asked, I'm going to of course show you the rest of the images. Okay, so you can see that this is a kind of nondescript, you can argue that there's more delayed enhancement here. So this is obviously not a benign lesion. So this is LRM. You can see here on the pre, this is there as well. So this was LRM, right? So patients, once they have LRM, they go under for biopsy, which this patient did. And this was a HCC with CK19 positive staining. So this is like very aggressive, one of those very aggressive subtypes, proliferative subtypes of HCC. So patients with HCCs which meet criteria for LRM and have rim arterial phase hyperenhancement, solitary, controlling for everything else, do worse than the HCCs which fall into LR4, LR5 category. And this is one of the reasons why, because CK19 positive HCCs more often will have targeted features indicating much more aggressive behavior. So this was resected. I'm pretty sure she's doing okay so far. She was okay through December 2021. Yep.
That was awesome. Thank you. I still need to watch your Rank and Ray lecture. You said that was where you described all the HCC subtypes. Is it Rank and Ray?
Yes, I do have that. Yes.
Okay.
Yes.
Question, if the rim, like say this rim had washout and I was thinking it's rim, but with washout and maybe it's a biphenotypic.
It's still LRM.
It's still LRM. Do you put LRM biphenotypic or you just say LRM?
So depends on how, usually I put LRM and then I will say differential diagnosis includes intrahepatic cholangio, combined tumor, or aggressive subtypes of HCCs.
Oh, good. Cool. Okay.
You can't tell
so
apart.
You include in LRM aggressive subtypes of HCC. If you think there's like some component that might be a HCC.
I have cases which look just like cholangio and they end up being HCC. About a third of LRM observations will end up in HCCs, and usually they're more aggressive subtypes. So again, if you look at, there's one study that had a pretty large sample size, and they looked at single resected HCC, and both overall survival and recurrence-free survival was worse in HCCs which were resected and met criteria for LRM, especially those that had rim APHE. They do worse. So yeah, no, that's why they need to be biopsied. Okay, so that was that. So that's one case. The next case is this. Okay, this is a relatively cool case as well. Oh, it's a pretty cool case as far as I'm concerned. This was a patient who had CT. Right now, the CT. Patient has history of rectal cancer. Of course, we just froze. Oh, unfroze. Okay, and this was noted, right? This is a new lesion, appropriately questioned to be thought to be a MET because it was new. And then there was this kind of vague heterogeneity on CT here, and who, you know, the person who read it wasn't sure if it's another. This wasn't also present on the prior study. Wasn't sure if this is another MET or what's happening, so they recommended NMR. And I'm happy that we did MR with EVIS because it demonstrated a very unusual or unexpected rather finding. So you can see this was the arterial phase, and you know, as expected, hypovascular metastasis, as expected behavior from rectal cancer MET. Notice that in that other area, there's really no focal lesion there. If we look at the diffusion, you can see that the MET restricts as expected. Really don't have anything specific there. And the key here is the hepatobiliary phase, right? So on hepatobiliary phase, you can see that the MET as a, you know, punched out lesion as we expect. But now notice that on the liver is not normal. So like if I zoom in, and if you just focus on this part of the liver, this is what we expect the liver to look like in a healthy person, where you see the, you know, the vessels as kind of black lines, but the background is uniform and hyper enhancing. In this patient, you can see that the parenchyma has a structure to it, has a texture to it. It has a very kind of like subtle reticular pattern to it. You see it?
SOS.
Yes. Right.
Wow,
so,
I can't believe you have so many cases of this.
So this is, so okay, so this is cool part because I called SOS, right? So sinusal obstruction syndrome, the patient wasn't appropriate chemotherapy drugs, and I said, you know, SOS. In tumor boards, in a tumor board, the clinicians kind of scoffed at the diagnosis because the patient's liver function tests were okay, and there was nothing that they thought indicated that the patient has SOS. So they thought I was crazy, per usual. No, I'm kidding, but they kind of did not totally believe the diagnosis.
And then they went to the OR and they were like, Victoria, the liver's blue. Right.
So they ended up biopsying this because they did the, why did they do the biopsy of the lesion? I don't remember, but I totally forgot what, but they ended up doing biopsy of the lesion and of the liver, and the biopsy of the liver demonstrates like classics, like the description is just perfect, you know, like the typical SOS. That's what it was. I think they were going for resection, and then they said, okay, fine, if Victoria is not crazy and she's right, then maybe this is somehow going to affect how much we can resect. So let's do a biopsy before we go. And so they got biopsy, since they were biopsying both the normal, you know, the non-cancerous liver and the tumor confirmed to be adenocarcinoma, and then the pathology came back from the liver, came back as SOS. The interesting part is that I just got an email from pathologists, and so they resected the patient. They went to the OR. That's about 2 months since the scan, and the tumor on pathology is 8 centimeters. So they called me and they're like, is it possible that this is not the same lesion? Like he said, 1.8 centimeter, like they showed me the pictures, it does measure 8 centimeters. And I'm like, and I showed them the picture, I'm like, this is a spherical lesion, 2 centimeters in diameter, really nothing else. So this tumor really has grown in 2 months, in less than 2 months, from 2 centimeters to about 8 centimeters, which is unfortunate.
Well, maybe they took them off therapy because of the SOS diagnosis, and then the tumor bloomed.
Possibly. The pathologist
Because
was
that's
very
how you
skeptical.
treat SOS, is removing the offending agent.
Right.
So for the residents on there, I know there's some residents on here. We're talking about sinusoidal obstruction syndrome, which is this breakdown of the sinusoids in the liver, with like hemorrhage into the area, and like sort of congestion of the liver at the sinusoidal level. And it's mostly due to oxaliplatin related drugs like Folfox, which is what they use for pancreatic cancer, but also some colorectal cancers. And then also bone marrow, patients who have stem cell transplant for bone marrow diseases. So those are the classic like clinical scenarios, but Victoria's shown us several like awesome cases where on EOVIST, you can't see it on any other phase, but on EOVIST, you see this like heterogeneity. And when they have that congested liver, it's called blue liver syndrome. And if they go to the OR at that time, it's super congested. So if they like try to do a wedge resection, it'll bleed like crazy. So usually they try to take them off of those drugs before they do the surgery and try to reverse the SOS.
Right. So then this slight heterogeneity that we saw on CT right there is just a focal area that ended up showing up as heterogeneity. But that's just that's the SOS. And sometimes you can, like if you pay very close attention, you can see that the liver, even on CT, is a little more heterogeneous than usual, but it's very hard. It's not possible, you can see that, right? But that, that's very non-specific on CT. More likely this is some sort of, you would see this with some sort of chemotherapy related steatosis, but this is what it was in this case. That was a pretty cool case.
It also seems in the end, the tumor biology of that MET was pretty bad, because maybe if it was 2 months off therapy, it like grew like crazy. So.
Right. All right. So this one is one of my favorites. So 2 cases are going to be the same kind of appearance. And this is like, a lot of times this appearance stumps the residents, but if you think this through, you can totally get like what's happening. So I'm not going to pimp anybody, but you can, these are in and out of phase images, and you can see that the liver is super bright in phase. You can also see on T2 that the liver is super bright. It's brighter than the spleen, which is not typically what we see. The liver is typically slightly darker than the spleen on T2. Notice with T2 fat side, the liver regains its normal appearance. So even just with these, you kind of get that this liver is quite fatty. Oops, sorry. So then you now can see that this is in and out of phase images here, in and out of phase images. So notice that on the out of phase images, there's in the ink artifact between the liver parenchyma and the intrahepatic blood pool. You can see that, right? So this is another indication of really severe steatosis, to the point where, as far as MR is concerned, this liver acts like gross fat, right? Because normally we see in the ink artifact on the junction, on the interface between the fat and water. So vessels are water as far as MR is concerned, and normally you don't see the Indian artifact here because it's water against water. But in this case, liver is so fatty that it acts like gross fat on MR, which is not great for the patient.
It also looks like between the T2 and the T2 with fats that you showed, it was fatting out. So yeah, it's pretty fatty. Correct. I haven't seen this with the portal triads, but is it also at the edge of the liver you're seeing it on that out of phase? Like there was dropout? Because I haven't paid attention to that on that in and.
So here so in this case, the Indian artifact between the liver and the fat is still seen. But interesting, you should say, because the companion case here has a similar finding, right? You have Indian artifact between the liver parenchyma and the intravascular pool. And now notice that there's absolutely no Indian artifact between the parenchyma and the fat. Gone.
That's even more
Notice
severe.
how we have, correct. So now notice that we have nice Indian artifact between the what do you call it? Between the stomach and the fat, and you completely lose this Indian artifact because it's such a fatty liver.
That's super interesting because if you just look at the in and out of phase here, it doesn't look like the out of phase, you know, if you just look at the parenchyma, it doesn't look that bad. So you wouldn't be like immediately saying severe steatosis.
So this unfortunately is like our, you know, free breathing protocol. So I don't have like good sequences to show you, but this is the best that I can. But you can see that the Indian artifact is preserved around the kidneys, around the colon, around the spleen, and around the liver. You see nothing.
That's super cool. Can you show the T2 and fat sat here? Just want to see if
here's
it's like,
the T2. You can see how much how bright the liver is with respect to. And in terms of fat sat, again, this is a free breathing protocol. So here's the T2 with fat sat. You can see now the liver regains the normal relationship with the spleen was darker. And I don't think we have the
and they change a lot between the T2 and the T2 fat sat. So that's your clue too.
Yeah. So that's another clue. So this one's 2 days prior, and you can see this is what it looks like. It's a pretty bad steatosis.
Wow.
This by the way is a cyst. So.
I was just about to say I have a case like this where the cyst looks bright and it's like an optical illusion.
Right. So you can see that this is negative 27. Anyway, so that was just, you know, cute little thing. The next case is another very interesting case. Super interesting case. As in, like, I've never seen this case, such a thing before. Okay, so this is a study done in 2009. It's relevant. That's why I'm giving you the date. But you can see patient has cirrhosis and then has this rim arterial phase hyperenhancing lesion, right? Very similar to the first case I showed you. It doesn't really have kind of ill-defined, sort of almost picks up contrast in the delays. So this is again with the LRM, you know, once you, again, any one of the targeted features, rim arterial phase hyperenhancement, peripheral washout, delayed central enhancement, all of that immediately goes into LRM category. So in this case, this is pre-LIRADS, but they thought it was some sort of atypical lesion, so this was biopsied. And original biopsy came back as poorly differentiated carcinoma with CK19 positivity, which is again similar to what I showed you before. That when I got the path, looked back in the path, I'm like, oh, cool, another CK19 positive HCC. Then this patient had a complete resection, and with full resection and with full, you know, with full immunohistochemical profile, this ended up being intrahepatic cholangio. Okay, so intrahepatic cholangio in the setting of cirrhosis, patients who have cirrhosis are at risk for intrahepatic cholangio, although not as much as HCC. Okay, so far nothing unusual. Patient actually did very well. I don't remember. The patient had resection and was doing very well. So this is in 2009. So in 2020, the patient had a follow-up MR, and they noticed a lesion. Hold on, actually 2019. So what, about 10 years? Sorry, here, not 2020. So this was, just give me a second, I'll pull it up. So this is what the lesion looked like. Okay, so this is the portal venous phase. You can see it's very unusual, right? Kind of, you know, almost like a cyst, right? If you squint very carefully, you can see in our arterial phase there is rim peripheral hyperenhancement. On the T2, right, you can see it's not a cyst. Maybe there's a necrotic component here, but it's kind of moderately T2 hyperintense. And so this again is a very kind of unusual appearing mass, right? And this is LRM, okay? Because this was quite unusual, the patient had biopsy. And I'll show you where the needle ended up being. So this is the CT right before the biopsy. You can see the lesion is right there, but again, with rim hyperenhancement. You can see that the biopsy, here's the biopsy needle. You can see it's right where it's supposed to be. And I have, like, there are some post biopsy foci of air. You can see it's right within the lesion. So they got the correct target. The target was correct. So the path came back as well-differentiated HCC. So this is kind of insane because this patient now developed both path-proven intrahepatic cholangio, and about 9 years later came back with new HCC. Now, I don't know how much I trust the biopsy that this is a well-differentiated HCC. This has a very, again, LRM appearance indicates quite aggressive biological behavior. So I wouldn't necessarily trust the well-differentiated part. And possible that there are some biphenotypic components, so this is combined, but this wasn't resected at this point. This was biopsied, and then I believe she had ablation. Patient had ablation. And
I'm actually amazed that she's not developed more things, given looks like advanced cirrhosis and 10 years of like surviving from her cholangio.
No, don't get me wrong. Since then, she again, I don't remember the gender. There were other lesions. This was treated. This was treated. These were all cavities, stable. None of them were actually biopsied since then because they just met typical criteria for HCC. But anyway, but this was just such a weird looking lesion that they biopsied, and now we have a path proof that this patient developed both types of cell type tumors, which is pretty neat. Not for the patient, but it's pretty neat. And I think that I showed you everything else. Right, so I showed you everything else that I have. That's it for me.
Thank you.
Wait,
I'm gonna stop. Okay, this is my first case. So focusing on the pelvis, we can see the ovaries, the uterus, and in this area, there's a finding.
This is almost like adenoma malignum, but in like the abdominal wall. Like, what is happening over there?
Nice. Okay, so tell me why you're saying adenoma malignum, which is a malignant process of the cervix. So we see solid parts, we see cystic parts. What is your differential for an abdominal wall mass in a female? Youngish female. Anyone? I mean, not just
endometriosis.
Yeah, good. So endometriosis, and then what's the other main thing on your differential? Like young female with an abdominal wall mass.
Like prior C-section, scar issues.
Yeah, so the other
but not with this appearance.
Not with this appearance, yeah. But the other major thing to think about is fibromatosis or desmoid.
Fibromatosis.
Yeah, so especially in a patient who has a history of FAP or Gardner's. But like Victoria said, this looks much more like a scar endometrioma. It's actually the biggest one I've seen, this kind of beautiful one. So you got this dense T2 hypointense expansile kind of soft tissue mass and all these like cystic spaces associated with it. So that's the T2, and this is the T1 pre-contrast. And this kind of clinches the diagnosis. So desmoid does not typically have T1 hyperintense blood products in it. And so you can see here, all of the cystic spaces have all these bright blood products in them. This fibrotic part, one thing to note about this is going to enhance. Typically, like if we have an endometrioma in the ovary, we don't like enhancement. We think about malignant degeneration. But when you have a scar endometrioma, it actually causes a lot of fibrosis that can enhance. So don't be alarmed. That enhancement is not malignant degeneration. It's just kind of a classic finding of a scar endometrioma. So this one, this patient did have a C-section. You can see their C-section scar right here. And then the other classic findings for a scar endometrioma is that they might have pain with their menstrual cycle, so cyclical pain. They have a history of a C-section. It has T1 hyperintense blood products in it. And especially if they have a history of endometriosis. I have had a couple of cases where we've biopsied it, like there wasn't, there in the literature, there are some patients who have developed this without a C-section, so people don't exactly know how that happened. Maybe there's some kind of like translocation through or involving the rectus abdominis muscle. But most of them have C-section. And then I biopsied a couple of these. And one point about it is if you biopsy the fibrotic part, it's often very difficult to get the pathologic diagnosis because it'll just look like kind of like a sea of fibrosis. So you kind of want to biopsy the edge where you think more glandular tissue will be. And you want to bring up the differential because then the pathologist will test it for estrogen and progesterone receptors, which you won't see in a desmoid. So there's a couple, even in the literature, there's a couple where on biopsy, they've been misdiagnosed as desmoids and they end up being endometriosis. So if you just get this, like this enhancing part, which normally when we do biopsies, we go for like the big enhancing part, but you might just get like a sea of fibrosis and they won't be able to definitively say. In this case, you don't really need a biopsy because it's pretty clear. Okay, going to my next case. So what do you guys think about this? This patient has no real history, middle-aged female, and then presented with abdominal pain.
Oh, wow.
Something like sclerosing mesenteritis or some with lymphoma or something like that.
Excellent. So when we think about like mesenteric masses, our differential definitely includes like, is this a mass? Is this mass like lymphoma? Sclerosing mesenteritis usually looks more sclerosing, like fibrotic tissue, maybe even with dystrophic calcifications. This one also has, a lot of stranding around it. So you could also think about a, carcinoid met, like a neuroendocrine met, but usually doesn't look this big and blobby. And it's not usually jejunal. It's usually from the ileum. So it's usually down in the right lower quadrant. Any other thoughts based on how this looks?
Guess the worst case of mesenteric paniculitis you've ever seen. But I would.
Okay, so she's bringing up. Yeah, mesenteric paniculitis, which often has like multiple lymph nodes and encapsulation. But this part looks to me, this would be like, I don't know, too big of a lymph node, right?
No, I wouldn't put that in, but
Okay, any other thoughts? So another thought we had, it's near the pancreas. So is it, is this pancreatitis? But it seemed pretty separate. And then, what is this big, more mass-like thing? And the other thing that we thought about was a hematoma. And you look here, a lot of this looks like blood. And then this part, even though it's kind of mimicking a mass, could just be a hematoma. So we got an MR. And this is what the MR looked like. So this is like a week later. You can see that the process is significantly smaller. It's very T1 bright. It basically, I'll go to the subs. So this is that T1 bright thing, essentially non-enhancing. That's a little bit of misregistration. And it's gotten a lot smaller. So this is, I think, we haven't biopsied this because we've decided that this is a hematoma. So just to kind of remember, here it's what it looks like on the T2. So you can see it just looks like you're walling off this hematoma. So don't forget about hematomas. They can mimic masses on CT. MRI can be your problem-solving tool. And you can get spontaneous hematomas. And actually, I want to show you back on that CT. There was one thing. These are more frequently associated with pancreatitis and pseudoaneurysms. And if you look closely here, we thought there was a tiny little pseudoaneurysm here. This person, that turns out they were super hyper anticoagulated with their Coumadin. And so we think this was actually just a spontaneous hematoma. But it kind of tricks you at first, looks soft tissue. So don't forget about hematoma. Oh, and the other interesting part is that it restricted diffusion quite a bit. So also don't forget that hematomas can restrict.
Ooh, I got burned. Oh, go ahead.
Okay, wait here, and then I'll just show you the ADC.
Now, I just want to say that I got, the first time I've encountered this, I was really burned. We had a post, like 1 month post liver transplant MR without contrast. And there was what looked like, you know, T1 hyperintense, T2 hypointense mass with really bad restricted diffusion. It was like a long time ago. And I was like, it looks like hematoma, but why would it restrict so much? And I couldn't find anything in the literature at the time in terms of what's happening. And I actually spoke to neuro guys, and they're like, well, I guess hematoma could restrict, but we really don't see it that much. And so I ended up calling it concerning for hemorrhagic mets. And in reality, this was a very common, well, not very common, but it's a common complication of liver transplant. It was just a hemorrhagic infarction of the right adrenal. So I've learned my lesson. Hematomas can restrict quite a bit.
Yeah, and actually the person who read this didn't have access to the initial CT to see that it had decreased in size and all this stuff. And so they were like very concerned about this, thought it may be a neuroendocrine met, et cetera. I would say it's like even more restricting than, you know, like most malignant lesions. And so it's kind of like, wait, something weird is going on here. But yeah, it's definitely, that was like definitely a pitfall.
But I've also learned that when the signal intensity of a lesion is this bright on T1, it's usually going to be in the blood or protein, unless we're looking at melanoma mets. And like I found out, like live tissue, unless it's melanoma, is not ever this bright on T1.
Yes. Yeah. Actually, it was a beautiful, sorry, just to go back to it. This T1, this is exactly what a hematoma looks like. Often it has this rim appearance, right? Of different blood products along the edge that are like more congealed. So yeah, it's really nice. Okay. This is the next case. There is an adrenal mass. It's looking like this on the T2, central necrosis maybe. And it looks like it's extending into the IVC. This is the venous phase. You can see it's definitely extending into the IVC. I'll show you. Arterial was kind of just had like, you know, didn't have robust. Actually, this is not a good arterial phase. It's pretty late. It was, you know, kind of intermediate enhancement, and then by delayed, maybe some washout, but hard to say because we didn't have a good arterial, but it looks kind of like it's washing out. What do you guys think?
The most beautiful case I've ever seen of this entity, if I'm correct, what this entity is.
Okay, what do you think the entity is?
Adrenocortical
Okay, so that's exactly what we thought. We were like, oh, this is gorgeous. It looks like it's got the central necrosis. It's growing into the IVC. This is ACC until proven otherwise. Of course, it wasn't ACC. This was actually a pheo. So
Wow.
I guess the lesson I learned, it was a 7-centimeter pheo. One thing that was one clue is that it didn't change at all in size or vascular invasion in 6 months. So we were like, maybe it's just a slow growing ACC. I mean, I don't know exactly what the growth rate is, but in retrospect, but I mean, just with this vascular invasion, we're like, this is ACC. So I looked in the literature. I mean, there are reports of pheos growing into the IVC. In general, it's ACCs that love to do this. But now we have a case of this. So I don't know what the take home point is. You know, the patient did have hypertension, which you can see with both ACC and pheo. ACCs can secrete cortisol. Pheos obviously might be even more hypertensive. This patient was kind of middle of the road. and they resected it. So I don't know what to say. But they did not have an adrenergic crisis in the OR, and they did not block them. So maybe it wasn't like the most super active pheo, but just so you know, they can invade the vein. Okay, this is a cool case.
That's pretty wild. Pretty wild.
Yeah. So for every rule, I mean, there's always like, you know, even if it's just 5%, you're going to end up seeing it eventually. Okay, I want participation from any of the residents or trainees. I'll tell you, this is the uterus.
Something with a giant feeding vessel into it.
Something what?
Like there's a feeding vessel into something.
Okay, there's a feeding vessel into this thing. So there's like this big thing and this big thing that do not belong. They're not normal, and they're separate. I mean, this is the uterus. So the uterus is here. So what would you call these?
Can I use a needle? I don't know.
Let's say these are supposed to be the ovaries, right? So what are you concerned about here?
Oh, I mean, they're almost like giant fibro, like solid lead small mass neoplasm. So fibromas.
Yep. So giant bilateral adnexal masses. Fibromas is one thought. Anything else? So you can think about, yes. So Krukenberg tumor. So, and that's one thing that should be at the top of your differential. So we've got possible Krukenberg tumors of the ovary. And so now we're going to look at our places that love to give Krukenberg tumors, which is stomach.
Bilateral Krukenbergs? Wow.
Well, yeah, Krukenberg is often bilateral.
Yikes.
Yep. Because it likes to just drop to both of the ovaries. So do you guys see anything? It's actually a really interesting case. I'll just point it out. So the stomach here can be tricky because the pylorus can be quite thick, but it looks a little thick here, and I'll show you the coronal. So this is what the coronal looks like.
Linitis.
Yeah, it's almost like focal linitis of the pyloric region. And then the other big clue is that there are these really big lymph nodes right next to it. Okay. So as soon as you see possible Krukenberg tumors, go look at the pancreas, look at the stomach, look very carefully at the stomach. Then it gets interesting. So they go and do an EGD. They say there's a severe stricture of the stomach. They could only get a pediatric tube through, scope through, and it looks very smooth and benign. And they take biopsies and it all comes back inflammation. So what do you guys do? What do you think?
Biopsy again.
Good. So the biopsy again, it comes back inflammation. But anyway, you know that this is a tumor, and that sometimes when you have these very linitis plastica tumors, they're actually growing submucosally. So the mucosa all looks normal, even though it probably arose from some area in the mucosa. It is now growing along the submucosa. And so they ended up doing a biopsy of the pelvic masses. We don't normally biopsy ovarian masses, but if they're solid like this is a mystery tumor, very easy biopsy here. And they end up getting signet ring cell of GI primary. And then they go and do a distal pancreatectomy. And this was actually all signet ring cell with involved lymph nodes. So the take home point is when you see Krukenbergs or possible Krukenberg, look at your stomach carefully. Don't just blow off something as a pylorus, look for adjacent lymph nodes. And gastric cancers can grow. And actually Rupa showed a case of this a few weeks ago where the biopsies, like it all looked smooth, biopsies were smooth, but they had to go deeper into the submucosa to actually get the diagnosis. So even if the endoscopy, they say it's smooth or the pathology says negative, you should stick to your guns and tell them to rebiopsy. Okay, I have one more. This is just a quick one, but a classic kind of differential case. So obviously not an eye test. Residents, what do you guys think? What's your differential for this kind of mass? So this is an anterior mediastinal mass. It looks very heterogeneous. So the mnemonic is the 5 T's, or 4 or 5 T's, which is basically the most common one is something of the thymus gland. So a thymoma or thymic carcinoma. If it's a thymoma, it's usually more well encapsulated and it's associated with myasthenia gravis. Thymic carcinoma is more irregular. It could be a large thyroid tumor or goiter. In this case, the thyroid was completely separate up here. It could be a terrible lymphoma, and it can be a teratoma or germ cell tumor. So we biopsied this, very easy biopsy, and this one turned out to be a B-cell lymphoma, which I think of all those is probably the best one to have. So this was the, this was the PET
This is
after.
really, Aarti,
Yeah,
this is really heterogeneous. This is really heterogeneous for lymphoma.
I know. I thought it was, I was not thinking lymphoma. I was like germ cell tumor. But
Yeah.
anyway, now you see actually after 2 months of chemotherapy, it's shrunk significantly, and there's just a little bit of FDG avidity along the periphery. So doing much, much better. Didn't need to resect it. It was like actually really involving the heart. So it's beautifully shrinking away. And in younger patients, more frequently Hodgkin's lymphoma. This one is in a slightly older patient, it's a B-cell lymphoma. Okay, that's all I have.